The discussion now, this is Dave Harshfield again. Lecture 13, we'll discuss so-called non-specific neck pain. My little pet peeve, I think that there's specificity to all findings. See that in the reports a lot. Non-specific neck pain means neck pain of which we do not understand. First of all, let's discuss a moment about why pain becomes chronic. Now, acute, we talked about trauma in the last lecture. That's acute pain. That's nociceptive pain. It's like heart attack pain, broken bones, so forth. That's a different sort of thing. Most of the chronic pain we're talking about is neuropathic. What that means is that there's a chronic low energy level in these nerve fibers, pain fibers, that create this chronic pain syndrome. Now, chronic peripheral pain over time can become literally hardwired into the nerves, which then go into the spinal cord. A lot of this chronic neuropathic pain is actually a memory. The original cause of the pain is often gone. Sometimes when we treat these with opioids will work. Narcotics and opioids will relieve pain for the first 4 to 6 weeks, after which they actually potentiate or help hardwire this memory. And the memory is actually hardwired within the spinal cord. So it's not necessarily a higher center phenomenon, which is why it's hard to outsmart chronic pain. So research shows that previously unknown role of certain brain cells are at play in triggering chronic headaches and neck pain for over 9 million Americans. The thought that pain medication is helping us ease the pain is misinformed. As we said, it works for the first month or so, after which it actually works against you. We found that neurons are not the only carrier of pain signals to the brain. The gray matter is considered the neurons. The glial tissue is the white matter. And actually, glial cells outnumber neurons 20 to 1 and have been shown to participate in this so-called hardwiring of our chronic pain syndromes. And there's a variety of ways, and we'll talk about those, from nerve damage to over-medication and so forth. So morphine and other opioids activate glial cells, which mean that those drugs that one takes to alleviate pain after about 4 to 6 weeks actually make it worse. Now, although MRI is considered gold standard, so to speak, I really don't agree with that. I think the clinical exam is the gold standard. MRI is used to prove clinical evaluation and for correlation, but should not be used as a standalone in any imaging study. So although it's considered the imaging method of choice, abnormalities have also been found in asymptomatic subjects. And in addition, many patients with normal, unquote, MRIs have neck pain. And then they're pushed into this category of so-called non-specific. And at the end of the talk here, I think we'll understand that any sort of trigger point or focus of pain generation is very specific. And I'll talk a minute about how we can evaluate these and treat them. 10% of subjects younger than 40 years old have disc herniations with no symptoms. So just a positive finding on an MR sometimes can be a bad thing. Subjects older than 40 years old, but almost a fourth of them had foraminal and central canal narrowing. And almost 10% of them had protrusions or herniations. So absence of proof is not proof of absence. And by that I mean if there is a normal MR of the C-spine, doesn't mean that the patient doesn't have neck pain. Again, the problem is most so-called experts are uninformed. It doesn't matter how many resources you have. If you don't know how to use them, they'll never be enough. As Albert Einstein said, I fear the day that technology will surpass our human interaction. The world will have, subsequent to that, a generation of idiots. And really we have folks that are way too dependent on little toys and Googling things and texting things and so forth. without using the brain. And most of the science that gets into the so-called non-specific pain area is really blurry. And I'll show you, and you'll see by the end of the discussion here, how very clear our understanding is of these features. The problem, I'm afraid, is, as Tesla said, until we learn to study the non-physical, we're not going to get to the bottom of this. And what I mean by that is oftentimes the physical imaging of static findings or absent thereof. When it's normal imaging, it doesn't mean that the patient doesn't have symptoms, because pain is not a physical finding. It's an electrical phenomenon or dysfunction thereof. And so therefore, being non-physical, it's mainly, we can't take a picture of pain. If you think about an MRI study, there's no imaging of the pain impulse. Now, we have done studies in mice where we would make their little foot pad hurt, and when we inject manganese into that foot pad, it would travel up the neuron to the spinal cord, to the brain. We can image, when the little foot pad was in pain, the traveling signal would utilize this manganese MR imaging technique. Unfortunately, we haven't been able to talk our residents into letting us bang them on the thumb and inject manganese. So in essence, we cannot image pain. And so there's the problem. There's the so-called non-specificity of all these imaging findings. I'm just going to try to help make a narrative here so that we'll maybe have a better understanding. A live human being is actually an electrical field. And the whole concept of being dead is being acidotic. Hydrogen ions plus ions is what happens to us that causes cell death. And so the whole game is the electron transport system, which allows us to keep zeroing out, neutralizing the buildup of the hydrogen ions so that we don't reach equilibrium or death. That is immeasurable in a sense that it won't show up on an imaging study. But now we have electrical studies like the autonomic nervous system. Quan's autonomic nervous system allows us to evaluate literally the electrical field in the body, and we can now measure the function of your body's overall magnetic field and pulsed electromagnetic forces. If you think about a heart attack, if you can put all the stents you want to in a heart that's not beating, it's not going to help. You can put all the medications in there, it's not going to help. The way you get the heart started is what? With paddles, with electricity. That's the non-physical. And so often, just by simply touching your patient, if you are healthy and they're ill, your electrical field will help to ground theirs out. The Chinese have done this for centuries and try to teach us that. And the acupuncture and acupressure points are actually now measurable. We can see imaging with thermal imaging, that's fountains of energy coming out of these corresponding points. So now we know it's the non-physical. So if you've got a patient with neck pain and all of his imaging studies are normal, rather than pushing him into a little group saying, oh, well, it's just non-specific neck pain, let's think a minute. Let's start to measure and consider utilization of the so-called non-physical. Although the cause of neck pain may be associated with degenerative processes or pathology identified during diagnostic imaging, the tissue that's causing the neck pain is most often unknown. And that's because these trigger points, although they're palpable often as a little nodule, we don't understand them. And then the fact that it's a chemical process and therefore an electrical process, because rather than push it into a non-specific neck pain, trigger points are not that, nor is patients that have fibromyalgia and these other non-specific terms. It's about the chemical reactions and electrical reactions of the nerve and soft tissues. Now, the structural information, here's a nice look at the trapezius muscle, the upper fibers here, and then there's the splenius capitis. Here's the levator scapulae. Here is an MR of a patient who had a herniated disc. Remember, we discussed this was a Nonavulsion type herniation, which meant it didn't pull a piece of the hyaline cartilage off, and therefore the body's granulation response could develop and therefore resorb the disc. And look what happened. The disc was resorbed and went away. This was 4 years after the initial herniation. And with physical therapy and upper cervical chiropractic care, this patient's disc herniation was resorbed. Well, let's say he developed a neck pain later in life, and here it is in 2010. So morphologically normal, but there's going to be times when, due to certain activities, that we'll have pain, neck pain, and if we do an MR and we find a normal, in this case, MRI, we would dismiss this as non-specific. But you know, because 6 years before that, if we had degeneration of the C6-7 disc, there was a reason that this particular patient had increased stress at this level for whatever reason. It could be occupational, whatever. Not having benefit of these 2 previous studies and just showing the patient showing up with neck pain with this study, we'd read it as normal. Knowing the patient had had this issue prior to that, I went in and injected along the facets and paraspinal musculature with our Prolotherapy, our 12.5% glucose, to tighten the ligaments. And I also did perineural injection just below the surface of the skin for the pain along the paraspinal soft tissues, and the patient's neck pain went away. So the imaging study was fairly normal. The patient still had neck pain. And the fact that I knew he had a C6-7 disc 6 years earlier, I knew there must be a weakness in and around these facets and maybe along the lamina. And so I just did a generalized sub-Q injection. We'll show you how this 5% dextrose, buffered dextrose, actually works to relieve the chronic neuropathic pain. No surgery. So what's new in the literature is that all this literature on non-specific neck pain, non-specific this and that. Neck pain without a specific underlying disease is a serious health problem. It's become a major cause of disability, and if we keep doing the wrong tests or misinterpreting those tests, we're going to continue to miss the pathology. The craniocervical junction is a perfect example. People do not understand the importance of the ligamentous structures of the craniocervical junction, and the fact that from the base of the skull, C0, through C1 and C2, that anatomical relationship is manifested by a beautiful suspension of collagen and ligament and connective static stabilizers. No disc are between the skull base and C2. The first disc is at C2-3. So in a patient with no disc herniations or fractures or anything obvious in the mid-cervical spine, we just dismiss them as non-specific. In the other synonyms with non-specific, it's indeterminate, or it's nebulous, or nondescript, or vague. All findings have some specificity if you understand them. So a fourth to half of workers suffer from non-specific neck pain every year, and the risk factors are known. The prognosis is multifactorial. It depends on if you bump into someone that understands this and how to handle it without using narcotic drugs and turns these patients into drug addicts, or doing unnecessary surgery with post-surgery failures, and that we use regenerative and nutritive therapies in conjunction with upper cervical adjustment. I mean, this is in the neighborhood of the neck. Now, we know craniocervical junction malalignment can also create mid and low back and extremity symptoms. We don't often think in the terms how important it is for the relationship at the craniocervical junction. But certainly when we're having headaches and neck pain, that should be our first consideration, and particularly in the face of a normal, unquote, MRI or imaging study. So the diagnosis and treatment of nonspecific neck pain and whiplash is also nonspecific. And so people do all sorts of things, unfortunately, most of them bad for the patient. We need to treat the problem. And when we do steroid injections and lidocaine injections and melt the nerve roots, we're not fixing the problem. We're sweeping it under the carpet. And when we give oral medications and make the patient drunk their whole life, particularly the old folks who makes them fall, we're not addressing the problem. And when we do surgery at a disc that just happens to be there and vaguely correlates with their symptoms, and then we have failed neck surgery, then we're certainly not doing the patient service. So we are developing a narrative now. We know how to take the patient's existing imaging studies, do appropriate studies to rule in or out certain things that we are interested in. The most important two things, remember, are instability and rigidity. Are the segments unstable, indicating ligament laxity or tears, or are they rigid, indicating maybe a remote injury or fixation? Those are the two most important findings on any of the imaging studies, and they're not going to be visible on a recumbent non-weight-bearing study. So that's why we're doing upright fluoroscopic evaluations like DMX and vertebral motion analysis, and then we're also doing upright MRs. So once we know what the studies are we need to do, we take into consideration the previous studies, and when we back into them, we almost always see the abnormalities on the prior study. It's just that the person reading the examination was uninformed as to what they were looking for. Generally, they're looking for a disc herniation or something to do surgery on, and thank goodness that's not present on most of these cases. Red flags, though, we need to rule this out. Make sure that there's no suggestion of cord compression, because your imaging studies can look relatively normal. Over time, you'll see an atrophic cord, and acutely you may see a swollen cord. But if you catch it in the middle of the course of the process, the cord will look normal on the imaging studies, but they'll have findings that you'll be able to test, the paralysis or muscle weakness or paraparesis, that we'll be able to say, hey, wait a second, there's something wrong, there's something not right here. The cord's not right. Make sure we're not missing cancer. We don't need to be postponing that diagnosis, and make sure that we're not missing an underlying infection or inflammatory process, and thinking in terms of mechanical issue, and when in fact it's more of a metabolic or inflammatory process. And again, metabolic processes are often chemical in nature, with substance P and other pain generators, but they're often misfiring on the electrical field. Again, here's our non-physical we need to make assessment of. Also, let's make sure we don't have vascular insufficiency, and in the neck we'd be worried that there could be a vertebral or carotid artery obstruction, and often this vascular problem, particularly vertebral basilar dolichoectasia, when the vertebral basilar arteries are asymmetric and the basilar arteries curvy and elongated, those symptoms can be positional. And again, here's a non-specific, a patient pushed into the non-specific box, and we can take them out of that box and say that no, the symptoms are having it from vertebral basilar insufficiency. Also in severe trauma and skeletal injury, these are not going to be generally put into this category, although maybe they had severe trauma, skeletal injury years ago, and then they're still here because we didn't treat them correctly in the first place. Again, we talked about all the musculature here, and the subtle, the head, the movers of the head, the capitals, longissimus capitis, splenius capitis, the subaccipitalis. These are all connected to the skull base and then to the neck. And here's the cervical longissimus cervicis and semispinalis cervicis. So you got head extensors and neck extensors, and head flexors and neck flexors. The muscles can be stretched and become painful, and we have trouble with the scalene muscles, particularly in patients with head forward posture over time, because they have a high fibrous content in a lot of these neck muscles. Once they get shortened, they stay shortened. And there were some folks who were actually doing Botox injections in the scalene muscle to relax it and let the patient get their head back so it can balance like a ball on a golf tee. The epicranial aponeurosis is very thick, strong, powerful structure. The occipitalis muscle is palpable just below that. And remember all the trigger points, and we'll talk about those. The lesser and greater occipitals, third nerve, these across the superior and inferior nuchal ridges are trigger points. And these shallow injections with buffer glucose can relieve a so-called migraine headache instantly. It's the most amazing thing ever. And then along the posterior margin of the sternocleidomastoid, about halfway down, is a ganglion. And from the ganglion arises the transverse cervical nerve, the greater auricular nerve, and then here's the path of the lesser occipital, and then the greater occipital, and here's the third nerve. And so these are all potential trigger points that are presenting as non-specific headache and neck pain that you can treat with shallow injections with 30 gauge half-inch Botox needles. But you're not injecting Botox, you're injecting this buffered glucose. D5 is isosmolar, and it's exactly the energy, the glucose level that these little nerve fibers need. Remember, neuropathic pain is from low energy, and what do the nerves eat? Glucose. All right, so if we're going to do prolotherapy, we'll mark off the spinous processes, an index finger over this. We mark these off to each of the vertebral bodies. This is how we access the lamina and the multifidus muscle injection, and then 2 finger breadths off midline, angled at 45 degrees is how we inject the facets. Again, these are our targets. When you're feeling the trigger points, they're easily palpable, even if you can't see them. Often on MR, they're invisible. Occasionally you see them on ultrasound, I'll show you in a minute, but mostly they're palpable. And they're easily palpable between the fingers, the little nodules. So you gather them up, make them sturdy, keep them still, and the fingers are pressed downward and apart to maintain pressure for hemostasis. And your little needle, you can inject right into that little palpable trigger point. And this is along the superior margin of the trapezius, which is often a big-time pain generator because the dorsal scapular nerve can come this way. And as we just talked about a moment ago, all those lesser and greater occipital branches may be in close proximity. So just one little injection, you might get an enormous amount of relief. Again, these fibers, we think in terms of innervation being these large nerves that we memorized anatomy, but in fact, most of it comes from these very small nerves that are actually arising from the insulation or the nervi nervosum that surround these nerves. So the pain fibers themselves actually are emitted to within a quarter of an inch or right within the skin surface. And this is where the low glucose levels or glycopenia is creating these pain signals in patients with this neuropathic chronic pain. An injection literally of 0.2 to half a cc at each of these trigger points instantaneously relieves the pain complex. Now I'll talk about, I've got another lecture to do about cell therapies, and I think you'll all be interested in that, and how we use those in conjunction with the upper cervical adjustment, meaning that before we do any injections, we might do a little glucose injection, but we're not going to do cell therapy injections until we get the patient's immune system really fired up so the gut's healthy, make sure the endocrine system's okay, because all those things have to be present before we can start using platelet-rich plasma or bone marrow aspirin concentrate or fat graft or other sorts of cellular products. Now, glucose works instantly, and oftentimes the first time I see a patient, just to get them into the system, I'll do a glucose injection, and their pain is just miraculously gone. It's the coolest thing ever. And now they have hope. Now they have a dignity of a proper diagnosis, and I'm treating with sugar water. They love that. And we've only known about this since 1863. I'll talk about how the information was sort of lost, and that we don't do a whole lot of cellular injection unless we're having to restore structures. And usually in neuropathic pain patients, there's nothing that needs to be restored in those folks, like a ligament tear in a knee. You need to restore the cruciate ligament integrity. Now, some of the craniocervical junction patients, the cruciform ligament's torn, and that needs to be restored. And so we're learning to do both anterior and posterior injection procedures to put cells around the cruciform and the tectoral membrane and the key static stabilizers to restore them, so that when you do upper cervical adjustment, the realignment will stay and you won't lose alignment. Now, it's not like this is brand new. 300 years before Christ, Aristotle thought, he wrote 2 works on the regeneration in the animal realm based on a regrowth of an animal tail. And out of nowhere, he says, he hypothesized that biological form originates from undifferentiated matter. That means stem cells. The way the little tail grows in these animals is that they have stem cells that are waiting there to produce and restore cells or structures that are missing. So it started over 2,500 years ago, the idea. And here's the other thing to remember. Stem cells don't become new tissue. The stem cells we inject into patients, or the cell therapies like platelet-rich plasma, that is not becoming new tissue. They work by influencing the microenvironment that will allow the patient's cells to make better regenerated tissue based on the matrix. Remember the concept, it's the refreshment cart on the golf course that brings all the Gatorade and the hot dogs out, but the patient's own golfers, they're on stem cells. They've got to amble over to the golf cart and accept this Gatorade and refreshment and then go back out and finish the round of golf, which in this case would be rebuilding the cruciform ligament. Again, here's our marking for prolotherapy. This is a little deeper therapy. The perineural therapy with the 1/2-inch needles and D5 are for instantaneous relief for neuropathic pain. The proliferative therapy is a higher concentration of sugar, so that when it goes into the tissues, it creates a proliferation, a kind of inflammatory response that helps tighten the ligaments. And again, here's the midline, and 1 finger breadth off, the needle is angled to about 20 degrees, and you go straight down, you're on the lamina. So you can perfuse the lamina, the epidural space around the ligament flavum, with this high test, so-called 12.5% glucose, and creates proliferation to regrow and restore and tighten the capsules. And also it will restore the multifidus muscle, which lives in the midline. And then 2 finger breadths off midline at 45 degrees, you go down and you tap right on the facet. And so you're going to tighten the capsular ligaments of the facet joints. Now that's prolotherapy versus the shallow perineural therapy for neuropathic pain. So another key point, regenerative injection therapy provides only temporary relief if it's not applied in conjunction with appropriate physical, manual, and chiropractic therapies. So this is not a single shot deal. This must be utilized, and with sugar, if you've had chronic neck pain or headaches, probably it's going to take 5 or 6 sessions of injection. But we're not injecting steroids. We're not melting anything. We're restoring the local environment by restoring the nerve, because it's in control of all the soft tissues, the sensation in the skin surface, and the proprioception and so forth. So the regenerative injection therapy is temporary, and it must be used with appropriate chiropractic as well as physical and manual therapy. So just think of regenerative therapy as being a pulsed immunorestorative therapy requiring more than 1 session. And if we're treating cancer, we know that we have to retreat with chemotherapy several times. And it's a pulsed immunorestorative approach for the chemotherapy for cancer. Same thing for this chronic neuropathic pain. It's a pulsed several session applications to restore the immune system so the patient can heal. And the way patients heal in the long term is you restore normal motion. It's like we talked about, if you've got a sore knee and you put it in a brace, it won't hurt, but it'll wither. If you've got a sore knee and you just keep walking on it and it's unstable with torn cruciate ligament, you'll wear out the knee too fast. But if you'll restore it with cell therapies to reconstitute the cruciate ligament and collateral ligaments to stabilize the knee, and do the injection therapy of the glucose around the knee to decrease pain, the patient can walk. And the walking, but not limping, not antalgic gait, but normal gait, will restore that knee. So long-term positive outcomes are direct function of pre- and post-treatment gut immune system rehab, coupled with pre- and post-treatment chiropractic and physical rehab. More so actually than the injection therapy. So again, if we're going to do glucose for pain relief so that they can complete their chiropractic therapy and motion and so forth, great. But if we're going to use cell therapy, we need to make sure their gut and immune system is ready to go, because the way that it works maximizes the injection. The things we inject into the patient are not going to fix the patient. It's going to help the patient's immune system fix the patient. Again, here's our little trigger points, our targets. And here's some of our more superficial targets. The rhomboid minor and major are that help suspend the scapula are very important trigger points, and the dorsal scapular nerve will travel up and over to go right down the back right here. If you got skull base issues, here's the capitis rectus minor and posterior, and there's the obliquus and vertical and horizontal. These are very important small extensors of the skull, but they also, particularly the capitis rectus minor, help moderate the position of the dura mater, so you don't pinch it when your neck moves. So what we're starting to do now is do restorative injection of the musculature around the skull base, and then put the needle deeper and deeper until we can get the injectate into the epidural space, and it crawls around in the front to bathe the cruciform ligaments and apical ligaments. And then we're going to eventually place the needle through the thecal sac so that we can actually do intrathecal injection. So multi-systems approach here for skull base issues. Again, these folks had non-specific neck pain, when in fact it's very specific if you know what you're looking for. To begin with, these trigger points are these little tight spots here, and stretches the normal musculature. Here's normal muscle here, and these are palpable. I have a colleague, Jay Shah from the NIH, that's doing research where he's taking this needle. It's a 27 gauge needle. Look how small that is. Here's a penny next to it. And you insert that needle into these trigger points. And what you do is you pump fluid in, and then with the needle in the trigger point, it pumps out, there's a little membrane here, so there's not a lot of cellular debris, but it pumps out the chemicals that are creating that trigger point and that palpable lesion. And I'll show you in a second what comes out is what we think. One of the things that we have learned is that in addition to peripheral sensitization, meaning that this chronic trapezius trigger point has been there for 20 years after their car wreck 20 years ago, the cause of the pain is gone. We just never did adequately treat the secondary issue with the muscle spasm and trigger point production, and we've actually sensitized the peripheral nerve in this region, which is the dorsal scapular nerve for one. And over time you get central sensitization where it goes into the spinal cord. So it's hardwired both peripherally and in the spinal cord. And like we talked about before, chronic pain is often not within the higher centers of the brain. It's right here in the spinal cord, just back and forth, back and forth. And that's why you can't outsmart a trigger point. It's not something that you can do volitionally. You have peripheral and central sensitization. But you stick a needle in here and put some glucose, and actually acupressure, acupuncture, dry needling, anything that disturbs the milieu, the microenvironment, and cleans out that sewer, increases blood flow, will flush all that stuff out. So you can have latent trigger points. The patient is unaware until you push on them. They'll tell you the active trigger points are right here and here. And it creates a general muscle dysfunction. Imagine the trapezius muscle on one side if you have chronic neck pain, and how that's going to make your head antalgic at the cranial-cervical relationship. Again, muscle trigger points are the most common and yet most underdiagnosed and undertreated component of non-articular MSK pain disorders. So again, here's a patient with non-specific neck pain, when in fact it's a trigger point. It's a myofascial issue. It's not non-specific, it's very specific. And it's as clinically palpable. You don't need an MRI, although you probably do one to rule out other causes. But once it comes back negative, then instead of telling the patient there's something wrong with you, you're going to actually treat their myofascial issues. Now, immunology guides to skeletal muscle regeneration. Underlying muscle regeneration has been investigated for the last century and a half. And it's well established that skeletal muscle has an innate capacity to regenerate these muscle stem cells, so-called stellate cells. And if the muscle injury is minor, the healing process can lead to normal and functional tissue. But if the extent of injury exceeds the regenerative capacity of the tissue, as it does in high-grade injury or in older folks or patients with weak immune system, it results in loss of contractile muscle tissue and then development of fibrosis and dysfunction, like the scalene muscle in the front that holds the head down in patients with head forward posture. And so the injury location needs to be taken into consideration. And the hamstring muscle is one of the most commonly torn muscles in the human body. And it's also been described as demonstrating slow healing and persisting symptoms. Well, guess why? The muscle is a dynamic stabilizer of the knee, and it's trying to hold the tibia onto the end of the femur. What's really supposed to do that is an intact cruciate ligament and collateral ligament complex. So the static stabilizers of the knee, usually anterior cruciate ligament, is allowing the tibia to slide forward abnormally, too much excursion. Positive drawers test, we call that. And when you have a torn cruciate ligament, the muscle, the hamstring muscle is trying to hold the tibia as well as move it. And muscle is a dynamic stabilizer. It likes to contract and relax. It doesn't want to be under tetany. And when you exercise or move a muscle under tetany, you'll tear it. So when you have a hamstring muscle, you need to be sure and fix the cause of the problem. It's the cruciate ligament tear, the static stabilizer insufficiency is the cause of the hamstring muscle, the dynamic stabilizer injury. And that's why it's so-called slow healing and persistent, because you didn't fix the cause. A lot of this happens at the cruciform ligament at the CCJ, and that's why these folks were trying to fix the cruciform ligament so that all these other soft tissue musculoskeletal structures can relax and everybody can have a nice time there. So again, here are the trigger points. Infraspinatus, a common spot. Here's teres minor. And it's just a never-ending cycle. You have sustained contraction from an injury or whatever, or you got a ligament insufficiency, so the muscle's having to hold the joint together as well as move it. So sustained contraction results in capillary constriction, so it's an ischemic area. And then you have low energy supply. We talked about glycopenia and how that causes pain. And then calcium concentration it goes up in the extracellular space. So when it goes into the tissue, what does calcium do? Makes it contract, which then makes the vascularity diminish and so forth and so on. Now, here is a grayscale image of the upper trapezius here. Here's the skin surface here on the top. Subcutaneous fat, that's that little thin layer, must be a skinny old person. And then here's the upper margin of the trapezius muscle, and here's some fascia, and then the lower margin of the probably the infraspinatus muscle here. You can kind of get a sense that this part on grayscale looks a little darker than that, but it's really hard on grayscale ultrasound, and even on MR, to see these trigger points but you can feel them. They're so obvious. Well, since they're stiffer than normal tissue, if you use elastography, and now with ultrasound, we have elastography ultrasound machines that allow the normal tissue to vibrate. We make it green, and the stiff tissue is dark. So now what we have here, here's another example, a hypoechoic trigger point here in the upper trapezius. You can kind of see it on grayscale, but certainly on the elastography, you see this very dark, stiff area and normal vibration out here, this green vibration. Now, within minutes after injecting that with glucose, look at the change in the grayscale from a hypoechoic area here to normal grayscale, and look at how everything is completely normal elasticity-wise. So we can fix these little muscle contractions and improve perfusion to the trapezius, allow the head and neck to move normally now because the trapezius is not abnormally contracted. There was another cause for non-specific neck pain that now that we don't really need the ultrasound, we just do it to prove this to folks. You can palpate these and you can inject them and they'll go away and the patient's asymptomatic. You want to take pictures of them, go ahead. It's kind of what I do. Now here's what happens at the course of injury. You may have a direct muscle tear or contusion, and you get coagulation hematoma formation. It releases all these mediators and causes vasodilatation. So all the vessels around the artery and the veins vasodilate, increase blood flow to try to, once the blood, if there's any hemorrhage is stopped, platelets stop that. Once that happens, and we want to in with the good, out with the bad, we want to flush all that out. So vascular permeability goes up. So now all your little infiltrating immune cells are in the site of injury. And cytokines, cell kinetic movers, are little information proteins sent, and it's a conversation between the body's immune system trying to repair this injury in the muscle. Now, we have macrophages, and these tend to phagocytize microbes and things that aren't supposed to be there. But an M1 macrophage, like in us adults, is pro-inflammatory, and it'll actually create more inflammation than you need, and over time it'll actually can precipitate chronic pain. What we want is a smart, educated M2 macrophage, which is actually anti-inflammatory, and it can't scar. It only knows how to restore. And the way you differentiate an M1 to an M2 macrophage are with these new amniotic or perinatal tissues that have a heavy chain hyaluronic acid that is specific to this. And so that it educates you, inject this amnion in an area that's injured, and it'll make sure that you heal like a 2-year-old baby and not a 200-year-old man. I'm not 200 quite. So the pro-inflammatory milieu is maintained by our standard adult M1 macrophages, and what we want is an anti-inflammatory with M2 macrophages to create an environment that leads to the termination of inflammation and allows tissue regeneration. Inflammation and regeneration are two very close chemical processes, but you can see the difference in overinflammation versus what you want to turn that down at a certain point, so you allow regeneration to occur. Here is John Hilton, born in 1805, lived till after the Civil War. The Hilton's Law, he wrote in 1863, and basically said the principle that the nerve supplying a joint also supplies both the muscles that move the joint and the skin covering the articular insertion of those muscles. This means for the first time back in 1863, we understood the nerve around a joint, whether it be facet joint or C12 or COC1, all the nerves around those joints are more important than the bones that make up the joint, the hyaline cartilage that covers the joint, the bones and the capsular lining and ligaments. If you don't restore the nerve, there's no point in doing anything else to any of the other structures, because they're not going to move on their own. No muscle moves on it. There's no such thing as muscle memory. That's your brain talking to the muscle, telling them what to do. You can have memory sequences in the brain that allow you to be more coordinated at certain activities, but the muscle is not remembering that. Now, the spinal column does have a memory, but we'll talk about that again at another time. So the principle is we got to restore the nerve around these joints. And in doing so, it makes the joints move because the muscle tendon units move them, and it also restores the integrity of the capsule, the static stabilizers. Now, how do we do it? Buffered 5% glucose, D5W. There's 1 million bags in every hospital, hanging in every hospital in this country. The problem is it's acidified. The USP, the US Pharmacopoeia folks, decided to make it acid. So instead of a nice neutral pH of 7.3 or 7.4, it's anywhere from 3.2 to 6.5. So we put a little drops of bicarb in there, and now we've got pH neutral isosmolar D5W, and that is awesome to inject in these chronic trigger points and for patients with neuropathic pain. So it's called perineural regenerative injection therapy, and Dr. John Liftoff is the master of this. He's from New Zealand, and he taught me everything I know about this concept. Now, what about this glucose going into these neurons, creating a healthy joint? Everything is energy, and that's all there is to it. And it cannot be any other way, and this is not philosophy, it's physics. So Einstein told us that everything is about energy. You can't be putting screws or plates or artificial joints and so forth. If you can put the normal energy back into, say, the craniocervical junction, you can restore that. But the way to do that right now is you don't want, pain is also an energy dependent process that goes up the afferent nerves. We want to turn the pain nerves off, turn that energy off. We want the restorative energy going the other way toward the battlefield to restore the area. So by using glucose, we can do that. We put energy, because glucose is what these cells need, to make ATP, which is their energy exchange. And we do that percutaneously. It'd be nice if we could actually use pulsed electromotive force, PEMF, coils, and we're using those, and some cold and hot lasers. And that's what we're doing, is imparting energy into these fields to help reset the abnormal the conversation going on. And chronic neuropathic pain is based on low energy glycopenia, and it can be changed with the mechanical introduction of a needle, which creates, by the way, the tip of the needle is a little drop of blood. Every time you stick the needle into a trigger point, you're creating microhemorrhage, which alerts the body to, hey, increase the blood flow and bring in the cavalry. Problem is, if the vessels dilate and all the blood gets there and the blood's sick, that's not going to heal much. So we got to think in terms of, before we start sticking needles in folks, we got to get their gut well, and we got to get their immune system balanced. And over half the time, the patients don't need any injections. Now, Tesla was another guy. If you want to find the secrets of the universe, think in terms of energy, frequency, and vibration. Nikola Tesla. So the therapies that we're using in chiropractic and physical and manual therapy are this very thing. And we're using frequency with vibrational ultrasound, and we're using energy by injecting glucose and other substances. But they're restorative substances. We're not going to inject steroids. We're not going to put electrical radio frequency to melt nerves. We're going to put energy in to restore the function, not to sweep it under the carpet. Now, you are probably undergoing the backfire effect, or folks that might be listening to this that disagree with this concept, that want to hang on to the idea, every one of my patients that I understand, I put them in a disc herniation or whatever category. The ones I don't, I want to put them all in one box. Non-specific neck pain. And I'm going to treat all them with drugs. Just this backfire effect, when you try to teach someone something that's not their own idea, it's a psychological phenomenon in which the more you try by using facts and figures to convince someone that they're wrong about something, the more convinced they become that their pre-existing beliefs are correct. So I don't want to do that to folks. I just want to say, open your mind to the fact that these so-called non-specific neck pains, think about it a minute. It's just that you don't know what the cause is. That doesn't mean it's not specific. And I'm ignorant all the time. I'm just amazed at how many times I'm wrong or I don't know. And by the way, that's how you learn. You learn when you study your failures. You never remember the questions you got right on the test. You remember every single one you missed. So you allow yourself to be wrong. And it happens to me several times a day. And if you're the smartest person in the room, you're in the wrong room. So you need to move out into the world of the unknown and quit trying to classify things to make yourself feel better. Oh, that's a non-specific neck pain. So you feel like, oh, I've classified it. I know what it is. It's like iatrogenic, physically caused or unknown cause. So these patients with pain, we now realize, are not measurable by physical means, maybe MR, CT, X-ray, ultrasound. It's electrical. It's a non-physical. But now we're getting to where we have autonomic nervous system detectors. We can see this high energy in the sympathetic system and so forth, particularly in post-traumatic stress folks. And now we're able to measure this electricity and then treat it with the same thing. So the non-physical, just because you can't see it and that there's nothing physically wrong, that's a good thing. But now we got to talk to the patient and say, hey, here's what's going on. You have a toxic environment here. Your gut's probably not well. You probably got inflammation in the gut. You probably had this injury for a long time, and we're going to turn it off. It may take 4 or 5 sessions of this glucose injection therapy. But we got to get C1-2 aligned so that 12-pound bowling ball will sit right like a golf ball on the tee all day long, instead of just wearing you out, weighing 60 pounds as you stare at your iPhone all day. Again, Nikola Tesla says the day science begins to study non-physical phenomena, it will make more progress in 1 decade than in all the previous centuries of existence. And we're on our way. Hilton's law, that the nerve trunk supplying a joint also supplies the overlying skin and muscles that move the joint. And now we know that pain is the most common reason for patients to seek medical attention. And then the primary cause of pain is the depolarization or firing of these unmyelinated pain fibers due to insufficiency of energy in the field, low glucose, glycopenia in the neighborhood. And it's rapidly calmed by introducing buffered neutral pH 5% glucose. So D5W, it's buffered to a pH of 7 to 7.4. Also, this 5% glucose is isoosmolar, so it's a near identical concentration inside and outside the cell, so it doesn't create trouble in the extracellular space. And the fact that it's neutral pH and not acidic to the nerve cells, it allows repolarization, stabilizing the cells in the vicinity of the injection. So neurogenic inflammation is coming of age. Now, here's of interest if you don't think the nerves are important. Not only to restore the joint, but they also are, when they're misfiring, can create the milieu for arthritis. So arthritis either doesn't develop or is significantly decreased in denervated joints. Think of this a second now. People have arthritis and inflamed facets and whatnot. We inject glucose in there, restore the nerve, and they feel better. Sometimes the presence of the nerve over time, it's active and it's overactive and it's acting up. In patients who develop inflammatory joint disease that then subsequently undergo a nerve injury like hemiplegia or polio, show sparing of the inflammatory joint disease in the denervated joints. Now this is why radiofrequency ablation or melting the nerves caught on was so popular. It decreased the amount of inflammation. The nerve supply is necessary for the development of arthritis. So let's melt all these nerves and put steroids in and all that. Well, short term, that's why they worked. But long term, you need that nerve. It's there for a reason. You need proprioceptors and vibrational and mechanoreceptors and so forth to know where to hold your head and how to move. So when you kill the nerve, it'll stop the arthritis, but then the joint won't function normally and it'll actually wear out faster, but it won't necessarily be an inflammatory arthropathy. Osteoarthritis is probably a low-grade inflammation as much as it is a mechanical arthritis. So denervation experiments and analogous observation in patients clearly indicate significant role of neuroregulation in inflammatory reactions, including arthritis. So our approach is to restore the nerve and let it work normally rather than trying to kill it. I mean, again, it works short term, but so do opioids, 4 to 6 weeks, and now you got an opioid addict. And so does steroids work for 4 to 6 weeks, and then now you got somebody whose ability to make their own steroid in their adrenal glands has been compromised, and they're diabetic, they can make them sick. So we got to think about what we're doing. Now that we're so smart, and now these are not non-specific patients, let's quit treating them with non-specific therapies. Again, shallow injection of glucose right below the skin, and this is right in the level of the axillary nerve, can really relieve a lot of shoulder pain. And this talks about how hypotonicity, and when it's isotonic, there's as much water going in and out of the cell as much going in as there is going out. And if you put in high concentration, like 12.5% glucose, it's hypertonic, and it'll actually suck the fluid out of these cells and make them small. And in a certain sense, it actually is healthy for the cell to change size because it makes the cytoskeleton, the microtubules, move, and it's like doing microscopic push-ups. And also remember this about red cells. They don't have an insulin receptor. They get their glucose by diffusion. So when you have high glucose in your bloodstream, you get a lot of sugar across the membrane into your red blood cells. And when you're in starvation mode, then they're kind of starving as well. Something to kind of think about on your diet. Now, the latest revolutions, pain is simply caused by low tissue energy level. This is the chronic neuropathic pain. And now appears that neuroglycopenia, or low sugar levels, detected by the nerves lying in the tissues, is the cause of this neuropathic pain. And neuropathic pain is therefore a signal to the spinal cord and brain of low glucose areas in the involved tissue. And neuropathic pain is to be differentiated from nociceptive pain, which is not associated with neurogenic inflammation. In other words, heart attack pain, broken bone, nociceptive pain, you need lidocaine to treat that, which is an anesthetic. If, for instance, your shoulder hurt and you put lidocaine in it, your shoulder wouldn't hurt, but you wouldn't have a shoulder. The sensory motor, it'd knock out pain, sensory, and motor. Anesthetic, lidocaine. And that's what you need for heart attacks, relief of heart attack pain and broken bones, acute pain. Chronic pain, on the other hand, you just need an analgesic. And sugar will just relieve the pain, but leaves motor and sensory. So now you treat these folks with glucose injections, and now they can go through their chiropractic and physical therapy, because how do we heal? Move. But we've got to move correctly, and we need experts that know how to train patients to do it. And we need to have pain control besides narcotics and opioids, in melting nerves and so forth, things that sweep things under the carpet, and certainly no non-steroidal anti-inflammatories. Those are horrible for your kidneys. And they defeat your regenerative inflammation. You'll never heal as long as you're taking ibuprofen, Aleve, and all those non-steroidals. Arthritis doesn't develop in these denervated joints. So remember, the cells are negatively charged inside the membrane, and they're cruising along at about minus 70 millivolts. And on the outside, there's about 12 times more sodium than there is inside the cell. And some little stimulus happens, and the stimulus creates influx of positive ions into the cell. And at this threshold, the cell just totally depolarizes and goes up to plus 30. Well, how do you go from a negative to a plus? A bunch of sodium ions rush into the cell, and they're positively charged. And this is where lidocaine works. Lidocaine works on the sodium pump. So when you inject lidocaine in an area, sodium won't go inside the cell and it won't depolarize. But it takes 20 minutes. And again, it doesn't just affect the pain fibers, it affects the sensory motor. Now, once the cell has depolarized, then you got trouble. And that's what these little cells are mad about. They need to repolarize. And the way to get it from a positive 30 millivolts back to a negative 70 is to get the positivity out of the cell, and we do it by pushing out positively charged potassium. This is where the glucose works. It opens these potassium channels and allows potassium to flow out, and allows the cell membrane to go back to negative. In fact, way below, it kind of hyperpolarizes before it goes back to resting potential. So lidocaine works on the sodium pump, and to keep the cell from depolarizing, or the nerve from passing depolarization, and to get it to repolarize is the potassium pump, and that's how the glucose works. It opens the channel to allow a lot of these positively charged potassium ions out there and return to a negative internal charge on the cell. Again, superficial injection, perineural, for these chronic neuropathic symptoms. Here's another point. In medicine, we must resist the tendency to confuse association with causality. Now, what that means, for instance, pain can be associated with the physical injury, but the pain is not necessarily caused by the injury per se. As an example, ischemic pain of cardiac disease is not post-traumatic in nature, instead being a consequence of the acidosis and hypoxia on the nociceptors and heart muscle when you have a blockage to coronary flow. Like the claudication and rest pain in the lower extremities in patients with peripheral artery disease. Pain and claudication, or an ischemic heart disease, is environment of acidosis with low oxygen. Chronic neuropathic pain is acidosis with low glucose. Now, what I found is that a lot of these patients, particularly with lower extremity arterial disease, it's an acidotic leg, but in addition to being hypoxic and having low oxygen, it also has low glucose. So now I'm treating these limb ischemia patients with glucose injections in conjunction with cell therapy injections, and we're saving a lot of extremities. So the recent discovery that most neuropathic pain is simply caused by low energy level of tissue provides an explanation for the remarkable effectiveness of John Liptoft's perineural injection therapy. So the clinical observation, the rapid effectiveness of this glucose injection introduced the possibility that pain may be in part due to focal and local tissue energy depletion, and therefore its energetic loss of energy, which is a non-physical phenomenon. It's not necessarily measurable. So now, when glucose moves from the interstitial space when we inject it, it goes into the cells. And it's a large molecule. How does it get in there? And how does it stay in there once it gets in there? It's too large to dissolve through the membrane wall, but there's integral proteins, and it's termed glucose T transport, the glut protein, that utilizes cell concentration and moves the glucose passively. It opens and allows sugar to pass into the cell. So glucose in the GI tract also can enter cells through the secondary active transport system when sodium gradient inside the cell drives a transmembrane protein to import the glucose with it. Now, red cells contain this little transport. Remember, we said they don't have insulin receptors. They don't act like normal cells where the insulin receptor is stimulated and they take in glucose. It just comes, they absorb glucose from the bloodstream and to make energy through glycolysis. They just split a molecule, 6-carbon molecule into two 3-carbon molecules, 2 pyruvates. And for each glucose, they get 2 ATP. Now, when you're using glucose in an oxygenated cell, you get 38 ATP. So you'd rather do oxidative phosphorylation instead of running on an anaerobic metabolism where every glucose molecule only gives you 2 energy packets. So red cells contain this primary GLUT1. Muscle and fat cells have a lot of GLUT4, a protein found mainly in vesicles in the cell cytoplasm. Insulin allows GLUT4 vesicles to fuse with the membrane to increase the number of transporters found on the cell membrane and increase glucose uptake into fat and muscle. This happens in other cells as well. Now, once the glucose gets in there, how does it stay in there? Well, it's blocked from exiting the cell by a reaction of phosphorylation carried out by an enzyme. It's a hexokinase because glucose is a 6-carbon molecule. It's a hexagon. This hexokinase adds a phosphate group to the 6-carbon, converts it into glucose 6-phosphate, which is now negatively charged. And due to the lipid bilayer cell membrane having a phospholipid also making it negatively charged as well. So once glucose is inside the cell, the same charges, because the membrane is negatively charged, the glucose is also negatively charged. They repel each other, keeping it away from the cell surface. So again, electrical and chemical changes which are non-physical and are not going to show up on an MRI. Okay. Once we inject the glucose, this is what it looks like on an MRI. I just did this as a fat-weighted sequence. Each one of these little collections of water are my little glucose injections at each trigger point. I also injected some of them in the joint space. This is a patient for a shoulder arthrogram, so I use Dextrose, D5, instead of $1,400 worth of gadolinium. You don't need that, and it can be a dangerous contrast material if it breaks apart from its binding agent. So I use water, but D5 I use because it's healthy for the tissue. And you just do a water-weighted MR sequence. You got a beautiful MRI. Look at the labrum here, superior and inferior labrum. Here's the inferior glenohumeral ligament, the key static stabilizer of the shoulder. I mean, look at the anatomy. And there's no leakage of fluid out here, so the rotator cuff here, supraspinatus tendon, is intact. And the acromions here, so there's no outlet stenosis. All the information you need for a diagnostic arthrogram, you can obtain with buffered glucose into the joint space. Need a little longer needle, by the way, but then these little 1/2-inch Botox needles, I'm injecting glucose along these trigger points. And when the patient gets off the table, they're essentially pain-free. They can move their arm around again, and they go right back to the chiropractor's office and not back to the orthopedic surgeon's office. Now, what else is under the subcutaneous tissue right here? See these little blood vessels here? So when we put the glucose in there, and you have all these capillaries on the surface of the skin, region of the shoulder, here's an ultrasound before and 2 minutes after. Look at the increased blood flow. And here, this is from the surface of the skin to underneath the skin here. Here's the subdermal layer, the interstitial space here, and here's the muscle down here. And by sticking a needle in and injecting glucose, you can see these little gray bright clouds right here of the glucose. See how here's an injection here and there. Look at how this creates instantaneous vasodilatation at this capillary bed. So regenerative injection therapy creates an instantaneous pain relief because the glucose turns off the neuropathic pain fibers that are responding to glycopenia. It, because of the little needle stick and the drop of blood, fakes the body and it thinks it's been injured. And it causes vasodilatation. Remember, we saw that injury diagram a moment ago when once the blood clots a little tip of the needle, it's not going to go anywhere. It starts to release all these cytokines and vasodilation occurs. Here's the thing, if the patient's healthy, this increased blood flow is the cavalry. It's coming to repair this area. But if the patient's gut's not well, or the immune system's not very powerful, or they're fairly old and unhealthy, there's nothing in this bloodstream. This increased blood flow is of no consequence. So that's why the injection therapies are really cool. But the first thing you need to do is make sure the patient's ready for them. And that means getting their gut well, their immune system well, and the endocrine system. So a mere drop of blood, this is the other thing that's interesting. You put a little drop of blood on a petri dish and all the stem cells line up. And we don't know exactly why, but movement and growth of cells is affected by the connectivity between those cells. So they're talking to each other. Interestingly, we saw that disconnected cells undergo only random individual motion, but that strong cell-to-cell connectivities lead to much more pronounced collective and coordinated cell migration, spanning distances of micro and even millimeter length scales. So if you just put a bunch of cells in a petri dish and they're just going to look at each other, they're not going to do anything. You put a little drop of blood or plasma, something in that, cytokines probably, but it gets them started to move, and they move in neighborhoods just like people don't want to be alone. So the movement and growth of cells is affected by connectivity between the cells. Numerical stimulation model that mimics the shape and movement of the cells, both in the presence of absence of blood, was studied. Blood-deprived cells remain quiescent. They don't move. While the addition of blood activates cells, and they undergo spontaneous motion. So increased blood flow is a good thing. That's how we exercise. But when we have a little trigger point, we talked about muscle spasm and vasoconstriction, and then it gets ischemic, and then all this becomes a toxic cesspool. By the addition of blood, recreates a recommunication, a resetting of the milieu in this little cell group. They hang out in neighborhoods called niches, we call them. The simulations indicate that enhanced cell-to-cell connectivity causes cells to align more strongly with their neighbors, ultimately giving rise to large-scale collective motion observed in our experiments, and that's how you heal. Cells line up. Collagen has to line up along the lines of normal stress. If you put collagen in, or you put even cell therapy in, it makes collagen just forms globs unless the tissue is moving. So the electrical and mechanical motion allows collagen to be laid down along lines of normal stress. So our rehab requires physical manual therapy and chiropractic to make sure alignment's normal. And then if you're in pain and you're not moving, you're not going to restore your collagen connectivity. But once we get you out of pain, and we got a great way now with this glucose injection procedure to not use opioids or NSAIDs or melt nerves or do surgery, we can get you where you're pain-free, and it may require a few sessions. But meantime, you can do your chiropractic and physical therapy. So our skin cells are much more active and dynamic than previously thought. And blood-regulated skin dynamics occurs in many different situations. Now what we're trying to do is understand how blood triggers those forces inside the cells. And I think we're getting really close to that. And here again, these folks are using cells inside a petri dish. They're not using cells inside of a human being that then needs to go to do physical therapy. So we got silos of brilliant people that are not talking to each other. And I think that this upper cervical chiropractic group can sort of be the nidus, the connector for all these folks that are doing chiropractic care without considering C1-2. They're doing a lot of high velocity adjustment, for instance, or maybe just doing physical or manual therapy without doing realignment of craniocervical junction, or maybe just injecting and not doing any chiropractic or anything, just thinking this shot's going to make this magically work. We need to all work together. And in doing so. The science is out there. We just need to put us all in the same room. In the clinics that we're building around the country are so-called big tent approaches, in which the upper cervical docs will be in the arena. We'll have a big open air facility in the walking tracks in the middle with some workout exercise equipment, and the doctor's offices around the periphery. And you don't need 52 me's. You need two Dave Harshfields. You need 2 Scott Rosses, 2 Julie Mayer Hunts, and you need 2 of each of us, like a Noah's Ark. And you don't need all of us every single patient. But by having the nutritional therapists, the IV nutritionists, the podiatrists, the upper cervical, all those in the same room, and we're treating chronic disease now. Acute stuff goes to the hospital. Hospitals are great at acute care. This is not that. We've got to quit throwing acute answers at chronic questions. Aging is not a disease, but it can be painful and dysfunctional. But we want those folks. We don't want an emergency room. We want these people. Again, neuropathic pain is acidosis with low glucose, and claudication pain is acidosis with low oxygen. So when I'm treating legs that have claudication, I know they have low oxygen, and they're on anaerobic metabolism. So if we have no oxygen, you only get 2 ATP per glucose molecule instead of 38 in an oxygenated environment. So they need a bunch of sugar for energy production. And then that gives energy that's needed to power the cells. We use half of our energy throughout our lives powering the sodium-potassium pump. Think about that a minute. Half of the energy consumed in a human body is for keeping the sodium-potassium pump going. And that's 70 millivolt to 30 milli to plus 30, minus 70, so forth. That's life. And when that's over, that's death. And a lot more of the energy is to keep those hydrogen ions, those plus charges, neutralized, and that's the electron transport chain within the cell. Now here's a patient with a normal looking x-ray. Must be no problem, non-specific shoulder pain. No, here's the quadrangular space here, and here's where the axillary nerve lives, and literally the fuse box for the shoulder. By injecting glucose into this space, you can reset the shoulder. And by the way, shoulder is 30 muscles. We concentrate on the 4 rotator cuff muscles, but it's 30 muscles that control this shoulder. We need to think about the other 26. And look at all these spots where the nerves can be entrapped, like a herniated disc can entrap the C4 at the cervical spine, or the C4 nerve root could be entrapped right here at the suprascapular notch or spinoglenoid notch. And here's the axillary nerve here, the C4-5 contributions. So what we do is on MR, I know where the quadrilateral space is, right here where the vessels are. So I inject about 5 cc's of glucose, and that's what it looks like after I inject it. And within seconds, the patient can move their shoulder. It's amazing. It's like their shoulder, things we used to think were adhesive capsulitis. We put them under general anesthesia, their shoulder would move fine. So muscle spasm is pretty unbelievable at how it can keep a joint from moving. And you put some glucose in there and provide energy, they're going to start moving that joint. So does prolotherapy solution impact live cells and polypus? Yeah, it does. Because if it's too concentrated, D5 is isoosmolar, pretty much the same concentration inside and outside the cell, maybe a little bit more concentrated, but it equilibrates really quickly. 12.5% sugar and 25% and 50%, now you got trouble, or you got a little change. Osmolarity is the concentration of the solution. Water always flows from a less concentrated solution to more. So here's 12.5% sugar. See, there's more sugar molecules here, and here's the membrane of the patient. And so there's not as many glucose molecules here. 2 things going to happen. Water's going to flow out. Glucose is going to try to flow in, or whatever this molecule. Now, if this molecule can't get across the membrane, it can't equilibrate. So what's going to happen is water's going to come out of the cell. It's going to become smaller. Hypoosmotic over here, and hyperosmotic over here. Now, the body is the same concentration as 0.9% normal saline, it's called. It's the same amount of salt or salt water as in our bloodstream. So you get 9/10% normal saline. That's what they give patients in their IV bags. And common prolotherapy, now not the John Liftoff technique with the 5% glucose for neuropathic pain, but when we're trying to put a needle into a lax ligament and fire it up and get it kind of inflamed, prolotherapy therapy to tighten the ligament, we might use 10 to 15% glucose. So that's a much higher concentration, certainly not isoosmolar, it's hyperosmolar. So what happens to platelets in saline, and then what happens to platelets in prolotherapy? In saline, it's the same concentration outside as in, no problem. Platelets are fine, but when there's way more concentration outside than in, the water's going to run out of these platelets, and all that water comes out, and they're going to look like a raisin compared to normal. So when you use hyperosmolar compounds like hyperconcentrated glucose for your injections, you're really trying to get an inflammatory effect. Regenerative inflammation is what you want. But when we're trying to do injection of glucose, we want to use D5 because it's isoosmolar. Now, by the way, 9/10% saline is isoosmolar, and people have used saltwater saline for prolotherapy, and it does work. But think about it. Salt accelerates electrical impulses. It's an accelerator. Sugar is an insulator. So you can put salt water in somebody's hot ligament, and it will work, but it will hurt. Whereas glucose, you put it around a ligament, and it doesn't create the pain so much as it does. And both, by the fact that they have these little particles, one of them has salt in it, the 9/10% saline, and the other has sugar in it, the D5W, can create a similar effect, but you just don't want an accelerated electrical environment with the saline. You want a more insulated, slower electrical response. You've already got it too fired up. And you don't want to dry it out because that's what it does to the cells. Also, dextrose at 15%. Here's the control number of mesenchymal stem cells, and a number of 1,700 or so. And then here it is with 9/10% dextrose and 5% dextrose. So it's still going to be a little hypertonic, but the 10 and 15% dextrose really knocks out the mesenchymal stem cells. Now, injecting prolotherapy solutions with live cells or PRPs is not a good idea. You don't want to put high concentration in with your PRP or your stem cell injections. You want to do them separately. And Prolo should only be used at a different time when the cells are injected. You don't want to put them in there together. Now, some of these folks that have cervical symptoms, it's not just the sympathetic, it's not just the somatic nerves that come out that give you the radiculopathy, the arm pain, numbness, and so forth, and motor weakness. But there's also an additional peripheral nervous system, the sympathetic system. And these ganglia here are turned on too high. And this is part of what happens in the post-traumatic stress patients, is your fight or flight mechanism is turned on. And if you're getting chased by a bear, you're afraid of the bear and you're running away from the bear. Let's pretend like you could actually get away from the bear. There's some people that lay on the ground, and I don't get that. I guess you're practicing for being about to be dead, because if you lay there, I don't imagine he's going to fall for that. But anyway, let's say you run away from a bear, and you got the stress going on, fight or flight in the sympathetic ganglion. Once the bear's gone, or you're eating, I suppose, but once, let's say the bear's gone, you survived, it goes away. People that have post-traumatic stress, it doesn't go away. It's like the bear's chasing you all the time, 24/7. And you don't have to be in Iraq and be in bad situations like that. You can be in a bad job, bad marriage. These teenagers think that their lives are terrible. Their hypertonic, sympathetic tone, the energy in here is just like any energy, it runs downhill. So it runs into the central nervous system, and it freaks your brain out. And your brain's not able to connect to it and to rationalize what's going on. What we are starting to do is to inject with just standard dentist office Novocaine, but it's a ropivacaine. It's a long-acting anesthetic. You inject that with 5 or 6 cc's right there at the base of the neck on the right side, and that sympathetic ganglion is shut off for about 3.5 to 4 hours. It's like rebooting your computer. Whatever that high energy level that was stored in there is gone. And these people are doing miraculously better. Again, we're just now able to measure the electricity, but it's a non-physical entity. So we're not going to push these people into the non-specific neck pain category. We are going to understand that there's things we can't see and touch and feel, but that we can start measuring and we can darn sure treat. Now, this is what's around every facet. We're looking at, oh, I'm going to block the medial bundle branch dorsal ramus at that level. Yeah, you put an RF ablation, you're going to block that, all right? And what else are you going to melt? Look at all this stuff. All the proprioceptors, mechano, and nociception. So we got to quit that. And we're not smart enough to be able to rethread all that stuff. So we need to put some restorative solutions in here, glucose being one, and let the patient's normal motion, which creates energy, kinetic energy, to restore this joint. Also to remember, the central nervous system is brain and spinal cord. The peripheral nervous system are the somatic nerves that innervate the muscles of the extremities, and the autonomic system, which is both parasympathetic and sympathetic. Now, when we're treating the sympathetic ganglia at the base of the skull, guess what runs right past that? The right branch of the vagus nerve, which can also create remarkable symptoms, including neck pain. And once you dig down on these folks with headaches and neck pain, they got other issues too. We're starting to trace autism or autism-like symptoms to disorders of the vagus nerve. Now, this ganglion, this is on the left side. We usually will inject the right side. Sometimes you have to do bilateral, mostly just if you'll do the right side, it'll work. And this stellate ganglion has sympathetic ganglia that run all the way to the base of the skull north and all the way down the pelvis south. And so by injecting here under ultrasound guidance and putting bupivacaine, they get a very dense Horner syndrome on the right side of their face with constriction of the pupil, numbness, and so the whole deal. In about 3.5 to 4 hours, they wake up. Like when the dentist office numbing wears off after your dental work, that energy is gone or diminished. It's like we've rebooted their computer by turning it off. I do glucose injections whenever I'm in this vicinity. I'll try to over-inject when I'm posteriorly injecting, hoping I get a little glucose around the corner. You never know. I've had patients that have pretty remarkable results. I don't tell them that I'm treating PTS, and so many patients have this, and they're not aware of it. And again, it's a very simple, safe procedure. So in the Wall Street Journal in 2017, a colleague of mine published this. He's in the Army, he's in Special Forces, and he was doing an anesthetic injection of the stellate ganglion, and it relieved post-traumatic stress disorder. They've asked us to drop the D off of there. They don't like the disorder part, so we just call it post-traumatic stress, PTS. And this simple injection, this is Neuropin or bupivacaine. It's just a kind of an expensive lidocaine is what it is. And you inject that along the stellate ganglion, and you inject about 5 to 6 to 7 cc's. And it temporarily blocks the signal between that sympathetic ganglion and the brain and body. And when you wake up in 3.5 or so hours, you have turned off whatever that high energy, the bear's chasing me sensation that you got in Iraq or from a bad job or bad relationship. So this is a great way to treat these sort of symptoms. And these folks with non-specific neck pain, take them out of that box. Bring them in. Tell them you don't know what's wrong with them, but you want to know. And let them help you work through that. They'll appreciate that. The ultrasound right here is how we inject. And you can see the blood vessels. There's a lot of things in here you don't want to put a needle through. So be sure and make sure the person doing this for you, when I do these, I always do them under ultrasound guidance. So as we talked about, inflammation and regeneration are very closely related. Inflammation is important to start with, but to allow restoration, you got to turn that fire off. Too much inflammation is actually hurtful. Patients after a stroke, there's a certain amount of inflammation. They keep having inflammation. That actually does more damage to their brain. So we're giving them anti-inflammatories in the way of cell therapies. Exosomes know how to do this and shut the inflammation off. and turn on the regeneration. So osteoarthritis is mechanically induced. We know ligament laxity and whatnot, but also there's a bunch of cytokines, cell signalers, and enzyme mediators in a joint that create pain. So a lot of chemical, mechanical, and electrical issues going on. The mechanical things we can take a picture of, but we can't hang our hats on that. We're now able to see a lot of the cellular processes, and we can measure the enzymatic activity. So that's physical. But then the electrical part and dysfunction of the nerves and misfiring, that's the non-physical. We're just going to have to get comfortable with that. Also, the capsulosynovial joints are complex systems. The articular cartilage is aneural, so there's not any nervous tissue in your hyaline cartilage. And people go, well, I'm bone on bone. How do I grow my hyaline cartilage back? Will this injection grow it back? That's not how this works. We are improving the anatomic relationship of the two articular surfaces, and by having the proper amount of compression and frictions energy, it will restore the hyaline cartilage covering the joint and restore the function. And the synovial membrane makes a synovial fluid, which, remember we talked before, the lubricant and the hyaluronic acid that makes it more slippery than Teflon, and it actually makes a surface, the subchondral bone and the hyaline cartilage is actually can sustain more compression than Teflon. So a healthy articular surface is amazing. It can't be replaced with a prosthetic. And it certainly can't be fixed by melting or killing the nerves around it and sweeping the problem under the carpet. We got to fix that. So nociceptive stimuli that come from a microenvironment undergoing non-physiologic mechanical loading are pro-inflammatory cytokines, are damage-associated molecular patterns. We can measure these now. We can measure in the synovial fluid these DAMPS, damage-associated molecular patterns. We can correct that. And all these molecular patterns that we measure, these little proteins, that's what your cells are saying to each other inside the joint. They're talking. And now we can hear their conversation. So that technically is no longer non-physical. And what you need is to make them quit talking badly and get them to tell jokes or something. But the nociception comes from the microenvironment being sick. We got to clean that up. Also, let's talk about our second brain, and that's our gut. So we know that our brain and spinal column are the central nervous system, but we have 500 million nerve cells, and they're supporting cells inside a gut wall. Remember, there's 20 times more white matter than gray matter. So there's 20 times 500 million glial cells, in addition to the neurons, the myenteric plexus that lines your gut. Your gut is highly innervated. It's known as the second brain for its vast number of neurons and complex connectivity. So the enteric system has a crucial role to maintain a healthy gut and to talk to your brain. Most of the information traveling on the vagus nerve is coming from the gut going north. So the gut wall is home to many of the types of cells which appear to be evenly distributed throughout. But despite the chaotic pattern, because we don't understand it yet, the neural networks of the gut are responsible for these well-organized stereotypic functions such as stomach acid production, proper movement of food and peristalsis along the gut, communication with the immune system and the bacteria. Remember, the microbiome includes the microbiota, the bacteria in your gut, and your immune system on the other side of the wall. So the inside of the wall is the bacteria, monitoring the food, processing it, making sure that you absorb what you need, and making sure the stuff you don't need passes on. Your immune system's on the other side of the gut wall and passing on the information that it receives from the bacteria. And by the way, these bacteria are 4 billion years old. Those are our elders. Interesting, isn't it? These bacteria, microbes in our gut are smarter than we are. And all we got to do is keep them healthy. But if we don't, we can't heal. Again, if you think about the vagus nerve, this is what it looks like. It's everywhere. Vagus, vagabond is the nerve. You can see its condensed versions, but look at all the branches that go to the bladder, the gut, to the mesentery. Remember, the mesentery is the 79th organ now. It goes to the kidneys, and all this conversation is carried to the brain via this vagal system. 90% of the sensory nerves, the afferent nerves that go into the brain, 90% of the sensory nerves in the human body are traveling in this vagus system. Think about that. Now, when you have skull base injuries, remember, here's your hypoglossal canal, but then you got the jugular foramen, through which the vagus nerve passes, and also the glossopharyngeal nerve. So if you got a distended jugular vein on one side or an injury that creates trouble, the vagus nerve can be disturbed right here, to say nothing of the other cranial nerves. Right here is the right branch of the vagus nerve that we are inadvertently treating when we're treating the sympathetic chain. Sympathetic stellate ganglion is right here, the vagus nerve is right here. So sympathetic and parasympathetic of the peripheral system is sitting right here along the transverse process of C6. So we are actually resetting that. So I want to start talking to these folks that are mostly concerned about the post-traumatic stress issues, and talk to them about the additional positive effects they're having by also resetting the parasympathetic system as well as the sympathetic. And a lot of systemic pain and fatigue can be reset by this therapy right here. So research on the therapeutic potential of the vagus nerve stimulation indicates activation of either the motor or sensory vagus nerve bundles diminish inflammation. Okay, so a lot of folks are putting in these electrical stimulators in the neck to stimulate the vagus nerve for patients that have seizures and things like that. I'm saying I think that we can do intermittent injections without having to put a foreign body in that allow you to reset the motor and sensory bundles to diminish inflammation and pain. So low-level electrical stimulation interacts with the body's nerves to reduce inflammation, and that's the fundamental goal of bioelectric medicine. But rather than sticking a device in your neck, pretty soon we're going to figure out what the frequency is, and you can just, like Star Trek, with a wand, put it over the surface at the correct frequency and energy level. And they know now that stimulating the vagus nerve for as little as half a millisecond is enough to inhibit tumor necrosis factor production. And TNF is an inflammatory molecule. So again, anything along the base of the neck or within the neck, non-specific, could be related to vagal issues. And again, Oliver's his 11 other brothers, 12 of the cranial nerves. The olfactory and the optic nerve are really part of the brain. They're not really nerves per se. But then the rest are. Most of them have to do with moving the eyeball. And a couple of them, one of them listens and the other one moves the tongue around and so forth. Here's the mesentery, just as a final aside here. The mesentery is where the vagus lives, the neuroenteric plexus and so forth. And so it has to be healthy. And it's been designated as of 2016 as the 79th organ. And generally, there was considered to be 5 vital organs in the human body: the heart, the brain, liver, lungs, and kidneys. Well, this little guy right here, we might have 6 vital organs, because without your immune system, these little guys aren't going to survive very long. It was described by Leonardo da Vinci in 1508. So how are we, we just learned just after the Civil War that glucose works for pain. I guess it takes us a while to figure these things out. And as we talked about in another lecture, the 80th organ has now been identified, and that is the interstitial space between the skin and the muscle, and also interstitial lining of all the viscera in the body. So the interstitium is actually a component of the skin, interstitium, fascia. That's all going to be the integumentary system, and that'll be organ number 80, and we've got 11 organ systems and now 80 separate organs. So, and now people with Parkinson's disease have neck pain and stiffness and whatnot. You can pick this up early. These folks tend to have a history of constipation, so their gut's not well. And now we found out the people who develop Parkinson's disease, their gut bacteria is misfolding a protein in the gut that you eat. And when you absorb it, it's bent a certain way. It's not folded properly, and it's sticky. And where does it happen to stick? In the substantia nigra, the midbrain. So gut connections to the midbrain. We've also had gut connections related to multiple sclerosis. So your gut is your second brain, literally. And a lot of things that go on or don't go on in your brain are going to influence you. So a lot of folks with non-specific neck pain get that little shoebox out of the trunk of your car and bring those people inside and pull their cards out and have them come in your office and start talking to them about their gut health and endocrine system. And I bet you that what they have is neck pain with a very specific cause and treatable cause. So the human microbiome is a disease predictor. Disruption of the gut microbial community structure impacts overall health and can give all sorts of pain syndromes. The myofascial pain idea never struck me as appropriately discussed because your skin can't hurt. You can't reject your skin. There's something else going on, and it's your gut is on fire. You got a leaky, inflamed gut. You put that fire out, it's amazing how, and your skin is nothing more than your spacesuit. Think about that. The skin, the interstitial tissue, and the fascia, all that is your spacesuit. Tells you when things are hot, cold, vibratory, and it's also the source of most of chronic neuropathic pain. So an unhealthy skin integumentary system is not a good thing, and that's part and parcel to your gut. And remember, your skin is your ectoderm, and your gut's lined with endoderm, and we're mainly a big glob of mesoderm. The brain comes from ectoderm, so the brain and the skin are very similar in origin from ectodermal tissues in the embryo. The mesodermal tissue that makes your musculoskeletal system and so forth, fat and all that, in bone marrow is mesodermal. That's the majority of what we are. Then the endoderm is the lining of the gut. Here's a patient taking a cancer drug, and what happened was for metastatic melanoma, and here are some positive lymph nodes here along the left hilum and the left chest. It's circled in red here. And he already had an arthritic left knee from previous surgery. So the PET scanner, the positron emission tomography, that has this fluorodeoxyglucose and sugar, and it's taken up wherever there's activity. Well, the brain's very active, so on PET scans, a lot of uptake in the brain and nasopharynx, and in the kidneys and the bladder, which is excreted in some of the liver, but he's got a little tumor here. Well, he starts taking this PD-1 blocker. It's a chemotherapeutic agent, and his cancer goes away. But look at his arthritis. Oh my gosh, it just lit him up. So he has inflammatory arthritis from taking a chemotherapy drug. So it was an immune checkpoint inhibitor drug. So the chemotherapeutic knocked out the melanoma, but look what it did to his immune system. Created inflammatory arthritis. So again, we're using an awfully big hammer for a small nail, and we're just blasting these folks with cancer, with these huge toxic chemotherapeutics and radiation therapy and surgery and all this destructive therapy. Much like patients with Lyme disease get IV antibiotics. That's the last thing you want to do. They need probiotics. You don't want to kill their gut bacteria. That's what's going to save them. So in medicine, we resist the tendency to confuse association with causality. Pain is associated with physical injury, but pain is not necessarily caused by that injury per se. We talked about cardiac disease. A heart attack is painful, not in the way that your chronic neuropathic pain is painful. That's from low glucose levels, and that's neuropathic pain. Heart attack pain is nociceptive pain. So here's a patient that has an abnormality of the craniocervical junction. Everything south of that is trying to compensate. And the patient will walk in and say, my right ankle hurts. And if you're not paying attention and you're unidimensional, you'll try to treat their ankle. And you're not going to consider the fact that everything starts at the fuse box of the human body, and that's at C0, C1, and C12. Everything has got to go through here. Every cranial nerve, every central nervous system piece of information through the medulla oblongata and the cervical spinal cord. So if the craniocervical junction is not right, you're going to have a lot of compensatory problems. And so when they walk in with left knee pain, right hip pain, so forth, the first thing we think about, let's get C12 fixed. And a lot of times everything south of that gets better. And if not, let's don't put them on drugs. Let's don't put them on steroids. Let's don't melt nerves. Let's don't send them to the surgeon. Let's send them to a regenerative physician that knows how to knock out the pain patterns, and their antalgic gait goes away. They start walking straighter. You readjust C1-2. Half of those folks are fine. And the ones where your C1-2 adjustment doesn't hold, then we'll do cell therapy to try to reconstitute the key ligament stabilizers of the neck. Okay, I think that I'll stop here. In the next lecture, we'll talk about the spurring of the spine, and we'll be just about through.